Good evening. My name is Chris Johns. I'm with the Office of Cancer Health Equity and Community Engagement with Karmanos Cancer Institute, and I'm very thankful for your attendance tonight. With that, our welcoming statements will be made by Kimberly Keaton-Williams, who is the Chief Diversity Officer for McLaren Healthcare. Thank you.
Hi, good afternoon, everyone. Can you hear me okay, Chris?
Yes.
Okay, great. So for those who are not a part of the McLaren or Karmanos family, I wanted to just give a little context around McLaren and Karmanos, as well as diversity and inclusion at McLaren and Karmanos. So McLaren Healthcare is headquartered in Grand Blanc, Michigan. We're a $6 billion fully integrated healthcare system that includes 15 hospitals in Michigan and Ohio, ambulatory surgery centers, broad physician network, as well as commercial and Medicaid HMOs that cover approximately 640,000 lives in Michigan and Indiana. And we also have a home health and hospice division. And McLaren also operates Michigan's largest network of cancer centers and providers, which is anchored by the Karmanos Cancer Institute. And KCI is one of only 51 National Cancer Institute designated comprehensive cancer centers in the US. So now I want to just share with you a little bit about diversity and inclusion at Karmanos, which is a part of the McLaren family. So our mission for diversity and inclusion is we commit to an inclusive and equitable environment where everyone is valued and empowered for success. Our environment reflects the communities we serve, learns from all perspectives, delivers culturally appropriate care, and provides the best value in healthcare as defined by quality outcomes and cost. So our mission really looks at not only our patients, but our employees and the community and our governance and our accountability, corporate responsibility. And I'd like to just talk to you also about our commitment to our patients. So for our patients, we are committed to providing high quality, culturally competent care, regardless of gender or sexual orientation, gender identity, religious beliefs, or other individual differences that define the whole person, not just the patient. And for our patients, we are committed to communicating with compassion, respecting the cultural differences that have meaning to our patients and their families. Beyond our patients, we are committed to our communities. So we are committed to responding to the evolving needs of our community, advocating for changes that improve access to care, regardless of socioeconomic status, and driving changes that reduce disparities in care. We're also committed to our communities in being an impactful corporate citizen through inclusive community engagement that enhances the quality of life in the markets we serve. So with that backdrop in mind, in terms of our D&I mission and our commitment to our patients and our communities, I am really excited about our presentation today. I'd like to thank our Karmanos Office of Cancer Health Equity and Community Engagement and our presentation speakers today for bringing this important topic to us on cancer prevention in the American Indian and Alaska Native populations. Thank you so much, Chris, for the opportunity to give greetings today.
Thank you very much, Ms. Keaton-Williams. We appreciate the work that you do. Just as we move forward, Karmanos is just one of 2 NCA designated cancer centers across the state of Michigan. And with that, we serve 46 of Michigan's counties, which is close to 7 million residents. And we have sites across the state of Michigan that provide top-notch quality cancer care to Michigan residents every day. And a little more about our office. Again, as we've expanded the community outreach and engagement, has created our office. And we are committed to lifting the voices of communities across the state of Michigan to hear more about their concerns about cancer and their experience. I have the pleasure of introducing Melissa Buffalo and Wyatt Pickner from the American Indian Cancer Foundation. Melissa Buffalo is the Chief Executive Officer, and she's committed to working with and for tribal communities, both urban and rural, across the country. Wyatt Pickner is dedicated to improving the well-being of Native communities. He has traveled internationally for his work, and I greet both of them and welcome them to here today, and I'm going to turn it over to them. Thank you very much.
Good afternoon, everyone, and welcome. Thank you again, Karmanos Institute, for the time to talk with all of you today. Again, my name is Melissa Buffalo. We are here today to talk about reclaiming Indigenous health, cancer prevention in American Indian, Alaska Native communities. Wyatt, do you want me to? No. Okay. I was like, wait, do you need me to tell you every slide? Ampetu Washte, Tanyawahi, Melissa Buffalo, Imachi Apie, Michinchanu Muke, Kanji Wakpa Oyanke na Meskwaki Hematahan. Good afternoon and welcome, and thank you for this space. My name is Melissa Buffalo. I am a mother of two. I am, as they've mentioned, the CEO with the American Indian Cancer Foundation. I really like these next two slides because it just gives you a little bit more information about your presenters versus just getting right into the meat of the presentation. And I think you'll both hear from Wyatt and I today and hopefully walk away with the understanding that, you know, this work not only impacts us professionally, but personally. So this is my family, my extended family. The black and white photo on the left is my mom and dad and my sisters and I. I'm an enrolled member of the Meskwaki Nation in Iowa. I'm also Dakota from the Crow Creek and Lower Brochure tribes. You know, I introduced myself with my tribal connections, as well as being a mother of two, because those roles are very important to who I am as a mother, a community member, the work I do every day. It's just not a clock in and out. And not only do I do this work professionally, but I do this personally because I look at the impact that cancer's had on my families and those overall health disparities that we'll talk about. But I also look at becoming a mother, only to lose a mother to cancer within 3 months. So that unfortunately has deep ties to my family. And then my dad, who's in the picture, the colored photo, these are all his children and grandchildren. Again, my dad's health is failing, so we look at cancer and what we can do to comfort him on his cancer journey. So again, just thankful to be here and look at all the journeys I've been on, and I would not be here without the support of my family. So with that, I will hand it over to Wyatt.
Good afternoon, everyone. Again, my name is Wyatt Pickner. I am Hunkpati, Dakota, originally from Crow Creek, South Dakota. You know, like Melissa, I also want to go into a little bit of my more personal background because, you know, similar to Melissa, I'm very connected to this work. And it's so much more than, you know, just another job to me. In the work that I do here. And so, you know, again, I was born and raised in South Dakota. And I say South Dakota generally because while, you know, in all of my life, I've had, you know, technically one place that I've kept a lot of my stuff and my belongings and stuff, I, you know, have family and relatives that live throughout the state. And, you know, growing up, I would visit them a lot. And so I really feel like I grew up in the state of South Dakota and not in just one place. So to me, you know, home isn't just one place, but rather where my family and my communities are. And as you can see from this picture here, I come from a very big family. Represented in this photo are 5 generations, and it's not even half of the amazing support system that's provided me with so much inspiration and encouragement. And I do this to honor and respect who and where I come from. And I look forward to talking with you all and sharing about the amazing work that we do here at ACAF.
Awesome. Thank you, Wyatt. And again, I just want to thank the land that we're on where this presentation, if we've got to be in person, right? So we are on the land of the Potawatomi, the Ottawa, and the Ojibwe in Michigan. And we will share a little bit about some of the tribal context later. But again, as you saw in the flyer, the overview, again, we just wanted to share today's presentation. We'll give an overview of those Indigenous cancer burdens, those cancer health disparities, and the community needs. Go into that historical perspective of medical mistrust within Indigenous communities. Then we'll move into cancer prevention and policy from an Indigenous lens. And I have to give a quick shout out because I saw Chris Stockmeyer and Beth Seeloff on the call, who are very key in the work that ACAF does in terms of cancer prevention and policy. So, and then we'll kind of end with the best practices for health systems and working with Indigenous communities and share some of our culturally tailored resources and education materials that we use within the work we do. Next slide, Wyatt. Yes. Okay. So before we get into everything, again, just want to give you a good overview of the American Indian Cancer Foundation. I'm going to share a little bit about the vision and mission and where we are, where we started and where we're going. So again, ACAF is a national nonprofit that was established to address those tremendous cancer inequities faced by American Indian and Alaska Natives. The mission is to eliminate those cancer burdens on American Indian families through education and improved access to prevention, early detection, treatment, and survivor support. What I love about ACAF is, you know, not only is it geared towards American Indians and Alaska Natives, but it's Native governed. You know, a majority of our staff are Native, but we look at too those, you know, our staff that are non-Native and really, you know, giving them the tools and the resources to be able to carry this work out in a really good way that reflects the communities we work with in terms of their need. And so right now, ACAF is a young organization, as I've mentioned. ACAF was founded in 2009 and became operational in 2011. So we are celebrating our 10th year this year, which we'll share later. And I love our footprint. You know, we started small. We're so thankful to all of our partnerships and partners in Minnesota, as we are located in Minneapolis, Minnesota. You know, as a national org, our footprint has expanded. You know, we do our best to really reflect the communities we work with through our resources, through our tools. Yeah, so again, just, you know, emphasizing again that our board members and the majority of our employees come with an array of experience and expertise in serving the needs of our people. And we're, you know, looking at COVID, you know, we've gone remote, and a lot of our staff, you know, some of our staff are now working remote, and we've made it work, and we see how this is beneficial to us. Next slide, Wyatt. So our vision and the work that we do and why we get up and we come to work every day is really that vision where there's a world where cancer is no longer the leading cause of death for American Indians and Alaska Natives. And we really do that through hard work, culturally appropriate, community-based programming, looking at that policy change that really affords Indigenous people access to the best prevention and treatment strategies, so that we really do see a day where our tribal communities are free from those burdens of cancer. Next slide. So our vision, our mission, and then we go into that approach, right? We really do believe that Native communities have the wisdom to find solutions to those health inequities, but oftentimes are seeking that organizational capacity, expert input, and resources to do so. So our goal at ACAF and all of our programming is to really help the community meet them where they're at, and that this is a need that they are looking for and asking for. And I love Wyatt will always ground me in that. And I'm like, but they need it. And he's like, but are they ready? So it's a good balance. But, you know, we really do want to know that we give the community the tools and the resources, because oftentimes their community members will have a larger impact than we do. And as a small organization of 24 staff, if we can give those tools and resources to those communities and those clinics to deliver that service, we feel, you know, that impact and that approach will be even far more reaching. Next slide. So as we go through this, just again, a quick, as we'll go through this presentation, we'll get more into our programs and kind of what each program entails. So we really have 3 programs that lead all of our projects and our work. And our first one is our cancer equity team. I've been with ACAF for 2 years, and I was fortunate enough to start out as the cancer equity manager, leading some of our CDC funded programming. And so this team really looks at that cancer screening and early detection, and how are we getting in the clinics and really looking at those clinic systems improvement? How are we looking at their electronic health records, and how can we make small changes that have far and wide reaching impacts within their clinics and within their communities? How are we looking at those patient reminders to get those cancer screenings out? And again, we look at where COVID is at and really trying to re-engage our communities, but we know some of our communities are still focused heavily on COVID, and that makes sense, right? So we've, done our best to see where we can be innovative in trying to support our communities and our clinics from afar, but really trying to ensure that, at the end of the day, our goal is to really help with that clinic systems improvement, to get those evidence-based interventions and support our clinics in reaching more of their patients in their area. Our policy and prevention team really looks at that policy systems and environmental work. So a lot of that PSE work, I feel like our policy and prevention team has the farthest reach thus far in working with tribal communities, tribal leaders, and bringing in a lot of those policies that really help to improve the community's health and wellness, mental state. And really, so we look at some of these policies, and we were talking about that earlier, looking at those conversations that really help to move healthy vending, healthy eating forward. And so we look at those policies that just don't happen overnight. So really seeing where our policy and prevention team comes in to help do some of that work. And at this point, I'm going to go ahead and hand it over to Wyatt as the research manager, who could probably better explain the work that him and his team do. Thank you.
Thank you so much. So to go into some of the high level of the work that we do within the research and technically also evaluation, we really work with communities to identify the research questions and methods and funding opportunities that are, most appropriate for them. We support the collection and use of population-specific data, aiming to find those culturally relevant and community-specific health solutions that are both effective and resonate with those their individual needs and priorities. So we use some unique approaches in design, including survey instrument development and research methodology. Again, making it really a priority to identify how that data and information relates back to those individual communities. There has to be that need and purpose, for the community there in order to do that research. And so we definitely put a lot of emphasis on that. And again, going back to that approach of using that knowledge and wisdom from within the community and making sure that they, lead that work. So we'll talk some about what we, how we do some of that in rest of the presentation. But a lot of our work right now focuses on tobacco, and the significance that it plays in our communities. So we do, a lot of traditional tobacco work. We also have some lung cancer research that, we just put out a new lung cancer resource with the updated recommended guidelines on the screening for that, and we'll have an example of that as well. We also do some COVID-19 community engagement, and one of the most exciting things that we have coming up is developing our Indigenous evaluation work in materials as we work to evaluate all of the work that we do, as well as the work with our partners and stakeholders. So then going into, really kind of the inequities and some of the data that is out there. I believe one of the resources, I think that was shared, but is definitely on our website. We have an Indigenous or cancer burden booklet that highlights some of the information about what's happening in terms of cancer in Indian country. So American Indians, Alaska Natives face alarming inequities in cancer incidence and mortality. And we need to start with data when we talk about those health issues in our Indigenous communities. Having accurate data or any data at all has been a real struggle in Indian country. And this is for a variety of reasons. Most commonly is that we are tend to be a smaller population, and so we're seen as having small sample sizes. Another big one is racial misclassification. The data shown in the chart to the right shows that for American Indians, Alaska Natives, cancer death and mortality rates have increased over the past 20 years, while decreasing for whites over the same period. And so one point being that according to the National Congress of American Indians, this population may be described as an asterisk nation because an asterisk, instead of a data point, it's often used in data to display when reporting racial and ethnic data due to various data collection and reporting issues. Again, going back to small sample size, large margins of error, or other issues related to validity and statistical significance. And so, that's been a huge challenge for us as, we've done the work, because if we don't have good data to inform the work that we do, it's just kind of making the best guess at, what we're working on and hoping that it relates. And so, the information that is presented in this table here to the right is based on the publication that was put out in 2014. And so we can go through some of that because right now that's what we have to work with. And so it, highlights that the most commonly diagnosed cancers are breast, lung, colorectal cancer for women, prostate, lung, colorectal for men, and that lung cancer is the leading cause of death for men and women. Additionally, cancer is the number one cause of death for women and number two cause of death for men. The other important point to recognize is that, as many of you may know, is that there's, depending on the population that you're working with, there can be significant differences regionally or by region and within individual communities. And so, it's just important to look at some of those differences regionally or locally to understand where there may be hidden areas of concern that need to be focused on. And so that just really kind of highlights that need to work with individual communities on the priorities that they have. And so one of our big efforts is to go through and update, the data and information that's presented in this cancer burden booklet. But again, doing that is such a huge challenge for a variety of reasons. And so we'll be going through the process of identifying those, data sources that collect cancer information on American Indian, Alaska Native communities. More importantly, evaluating those data sources, because there's a lot of different factors and variables that can be included there, and going through and selecting the ones that are appropriate and relevant for the communities that we work with. From there, analyzing that data and interpreting the results. Sometimes I think that, the way that data and information has historically been presented on American Indian, Alaska Native communities is always, not done in the best light and can, cause a lot of harm as well. And so disseminating that information on multiple levels in an appropriate manner, because there may be some things that are not as appropriate to present on a national, very public level, and communicating and consulting with the communities that it's about on how that information should be presented and talked about. So, this kind of goes into how to do that information, really centering the needs and priorities of the communities that you're working with. In order to do that, it's not going to be a one-off kind of conversation or, an email, reaching out via email and saying, how can we help? It's really working to establish the long-term relationships with those partners and understanding the needs, showing them that you're committed to the work that's going on. And you're not just there, for a short period of time, to do a project or to meet the objectives of a specific project or a funding mechanism. We really have to have those deep roots in the communities and also investing in those communities. Melissa mentioned, that sometimes it's better to take the funding and resources and put that into building the capacity and infrastructure of those communities that know and understand their community the best, and how to approach those solutions or developing those solutions and implementing the programs, because they do need to be tribally led and community based. and rooted in that culture. That's what's successful in making the things work. We have to pull in and identify the experts that have, some of the information to help inform things along the way, but we really need to, put the community at the center and lead those efforts. And continuing to provide the support and resources as projects and efforts are ongoing, because it's, again, not going to be just, the trying to understand the barriers to cancer screenings. It's also like, what about the follow-up care, and continuing that conversation in the community all the way through, someone's cancer journey into whatever that health outcome may be. There has to be that support and resource at every stage. And most importantly, before any of this work can begin, is seeking the historical context and information and resources of the community and population that you're working with. It's not always some of the individual behaviors. There's a lot of other history and context that has to, be taken into consideration. And so then that's what we can start, this conversation with, of providing that some very general information about what this looks like for American Indians, Alaska Native communities. And then we'll circle back to this conversation and how to, start some of that work.
I love when we talk about, I paused. I love when we talk about data, because I didn't want to interrupt Wyatt, but it's like, when you're going through social media or looking at you get emails and articles, and, it's hard when you're not included in data points, right? Or you see that other races are, have just as many disparities, but yet American Indian, Alaska Natives are often left out of the conversation. And so really thankful for Wyatt and his team to really, how can we expand and build on these conversations to be included in data points, whether that's national, federal, local, state, but again, just really trying to push that and ensure that if we're not at the table, that we shouldn't have to be at the table to be included in that conversation and to be in that data point. So, and this is kind of my area that I love talking about as we get into that historical context. And again, you'll see where I talk about those personal connections and that personal contact to trauma. But just to give some background as we think again, what does federally recognized tribe mean? What does it mean when we work with urban and rural communities? And so that federal recognition is just that government to government relationship with the United States based on treaties. So there are currently 574 federally recognized tribes across the United States, and they function as their own government. They have their own relationship with the government, with the state government. According to the U.S. Census Bureau of the Census, there are 1.5% American Indians in the United States, or 4.5 million. Again, I believe that's just AI only, correct, Wyatt? So again, we think about where's that misclassification or that lack of accurate data when somebody is checking American Indian in another race. And so always just taking data you see with a grain of salt. And just to give context of how tribes now we see tribes, that do have state recognition that are trying to get that federal recognition back. Just to give you guys some context, in 2018, there were 6 tribes that did receive federal recognition in Virginia. Prior to that, in 2015, the Pamunkey tribe in Virginia received federal recognition. And then again, just to go a little deeper, in 2010, the Shinnecock Indian Nation, which is located in Long Island, pretty much neighbors with the Hamptons in New York, they've received federal recognition, but they filed in 1978. So that's more than, 32 years it took them 32 years to receive that recognition. So that's, how much time and effort and how many tribal leaders and committed folks within their nation to continue that fight to receive federal recognition, to have to fight and justify that this is their land, this is their cultural ties, this is their language, this is where their people, just giving so much historical context for the government to say yes. And then again, just giving that recap that there are 12 federally recognized tribes in Michigan, all making up Ojibwe, Potawatomi, and Ottawa bands. and being, you know, as I mentioned, being from the Midwest, a lot of the training I've done in the past, try to give that Midwest perspective, because I feel like I could keep you guys here till way past dinner time if we wanted to go deep into American Indian history, but we try to keep it as short as possible, just to give you guys enough context. So next slide, please, Wyatt. And so as I give these historical events that have, you know, have a huge impact on where tribes are today and where communities are and where we look at that historical and intergenerational trauma, just a few points. Again, these are not, doesn't cover everything. And then I just, you know, where it's easy for you to find more information on this one. So in 1862, the Dakota 38+2 mass execution happened in Mankato, Minnesota. At that time was the Dakota War of 1862. It was a Sioux uprising, and there were so many treaty violations by the United States. And so it was causing hardship within tribes, which weren't really tribes at the time because they were forcing them onto land, were not allowing them to leave. And again, just for context, the American Civil War was going on at that time. So from September to November of 1862, 390 Dakota were jailed in Mankato, and each of their cases were being reviewed, and those who were considered to participate in massacre or rape were to be hung. Now, one, let's look at that language barrier, right? All you know is Dakota, and you're speaking to somebody who does not speak your language, and so trying to understand that perspective of what you consider massacre. So again, lack of that understanding with that conversation. So within that, there were 38. So that number dropped to 38, but all 38 of those were hung, and those who were not were sent to Missouri and Kansas to work and basically, you know, considered jail. And so that is a very important historical point in the United States and in Minnesota, the Midwest. If you YouTube Dakota 38+2, there's a ride every year that they do in honor of those that were hung. And it's a very powerful documentary that follows a ride that they start actually near Crow Creek in Lower Brule and ride across the highway all the way to Mankato in December every year. And I could share this too later with Chris via email to share this information with you guys. 1868, we had the Laramie Sioux Treaty. And so again, this just shows all the land change that happened in the Midwest, which majority of South Dakota, where, you know, government agreed to give this set of land. And then you look at that next year, the Transcontinental Railroad was completed from east all the way to the westward. So next slide, Wyatt, please. Well, you look at that treaty that was given, the Black Hills was basically given to the Sioux in that 1868 treaty, but what happened in 1874, gold was discovered. So that definitely changed how things moved forward. And again, less and less land was in the hands of American Indians. And then 5 years later, we had the boarding school era that begun, which I'll get into a little bit more. And again, just for context, as we look at these things that are happening in the Midwest as the United States was growing and expanding, in 1886, the Statue of Liberty was dedicated. So we think about, you know, all the importance of that statue and welcoming, you know, folks to the United States. But yet in the Midwest at that time, there was so much war against tribes and American Indians. So just a little context there. 1887, the Allotment Act, which was basically breaking up parcels of land and making it harder for families to have large pieces of land or for tribes to own large pieces of land. And so just for an example, my mom has 12 siblings. And so the land that her mom and dad owned on the Crow Creek Sioux tribe nothing can do with it because now it's in the ownership of the 12 siblings, you know, some who have passed on already. So it's, you know, the intent of the government to break up that land and make it harder for the tribes to own it, which, you know, the tribes are starting to own that land and have larger pieces within the reservation. So it's really called a checkered board. So even though you'll see, if you look up a map of the United States and where the tribes are located, even though there's a plot, say within Pine Ridge or the Rosebud Sioux tribes, it's checkerboard. So it's not completely owned by the tribe. It's owned by, some of it's owned by individuals. 1890, which both of these pictures talk about this event. And we look at that event is sometimes called, you know, the last great war within the United States against American Indians. And they estimate that anywhere from 150 to 300 American Indians were shot or killed, mainly women and children. And again, that last major confrontation in the war against Natives. And so I won't go too much into the Wounded Massacre. Hopefully you guys, I think there's a movie that was made on HBO on that one, but great historical context. And, you know, these pictures are basically all of those bodies that were shot and killed were just dug into a grave. And so we look at that and how that stuff happens. I don't know what happens when someone raises their hand. I see a hand up. I'm definitely okay to answer questions as we go. It's probably easier. Next slide, please. Again, just kind of didn't really add the dates in here, but again, looking at the 1900s and kind of where we at today and thinking about how much this is not necessarily past history, but a lot of this, you know, impacts us today and where we're at and where we are with our healing. And we look at the historical and intergenerational trauma. So the Indian Removal Act was really just to remove tribes from or individuals from their land. And that really aligns with the Indian Relocation Act. And, you know, it was a large effort to get individuals from the reservations that were starting to be formed to the urban areas. So if you look at areas like Detroit, Chicago, Minneapolis, Los Angeles, New York, there are large pockets of American Indian you know, programming, nonprofits, housing that really, you know, was basically the government offered a one-way ticket to these urban cities that, you know, promised them a job, housing, you know, $200, which at that time probably seemed like a lot, but once the money ran out and they wanted to go home, there was no way for them to get home. So you'll see a lot of the housing, such as here in Minneapolis, we have Little Earth Housing, which is its own kind of area dedicated, you know, that's geared for American Indians and Alaska Natives here in Minneapolis. The Indian Religious Freedom Act, I forgot what year that one was, but we look at again, like, you know, American Indians were not allowed to practice their cultures and their ways, and it took an act for them to be able to practice their spirituality, you know, and it's just a hard thing when you think about not being able to pray to what you were brought up and raised with, and, you know, seeing that the importance of that to American Indian people. But then we also have to compare that to when we look at some of these other things, voting rights, you know, American Indians couldn't vote until 1965, but we look at those code talkers who were key in World War II. World War II happened in 1939 to 1945. So you had American Indians, you know, fighting for their government, for their United States, but could not come back to the United States and vote. The government food system is still something that is in play today. It is, you know, canned food, boxed food, food that was given to individuals on the reservation, not healthy by any means. I think the government's done their best to try and up these healthy foods, but you'll hear natives joke about how much they love commodity cheese, which is just processed cheese, but we call it like our brick of gold. And, you know, we find those things in humor to get us through, but forced sterilization from 1973 to 1976, the government authorized a handful of Indian Health Service clinics to sterilize women without their knowledge. And this one really hits home for me because between those 3 years, over 3,400 women were sterilized. And one of them was the Aberdeen Indian Health Service in South Dakota. I was born in 1979. Don't do the math, but right, I was born in 79. My sister was born in 74. If we were living in Pierre, if my mom and dad were living in Pierre in 74, I think about the trajectory of things that could have changed for us. And if my mom had entered that hospital. So knowing that you go to the hospital, right, for some checkup or to have a baby and you come out and not even knowing that you were sterilized, 3,400 women. And that's only what they counted. Again, let's question that data. How many more women did they not count that were probably sterilized between those 3 years? And they oftentimes targeted full-blooded women. And so when I think about these past traumas, they're not past, right? They're current. That could have been my sister could have been an only sibling, an only child. The Flood Control Act, if you look at this photo, this is Chairman George Gillette from the MHA Nation, Mandan, Hidatsa, and Arikawa Nation in northern North Dakota, basically signing away over 40,000 acres. Is it 40,000 or 4,000? Nope. They lost 155,000 acres of land to create the Garrison Dam. So I always talk about the dams that are located near some of these reservations, basically was land the government took. And so there's a quote, and I always tell folks to take time to look at the picture and really take in what the expressions are, right? Like he's crying, he's, knowing that how much land he's losing for his people. And to me, the foreman in the background just look like it's a waste of their time. And so he's quoted saying, "We will sign this contract with a heavy heart." And this was in, again, 1948. "With a few scratches of the pen, we will sell the best part of our reservation. Right now, the future doesn't look too good for us." And so this is a photo I always use in some of my trainings to just help folks kind of deepen their understanding of the impacts that are playing out today. Is that the last one? So the boarding school era, I don't know if too many folks are familiar with, in the news right now, there are a lot of Indigenous children remains that are being found in Canada on the boarding school. It started with Kamloops. There were 215 bodies found as young as 3. And so the United States and Canada both had a boarding school system put into play to forcibly remove children from their homes. Wyatt, you can go to the next picture. So that mantra in the United States was to kill the Indian, but save the man, right? And so the first boarding school was in Carlisle, Pennsylvania, named and that school was open from 1879 to 1918. The last boarding school in the United States was closed in 1996. I was 17 years old. And again, it just, we look at the impact of the boarding school, and I look at being a mom and where I could totally go down this crying path right now to think about somebody just showing up at your door and removing your child with no say. And how many right now, the count in Canada that they're finding of children's remains on boarding school grounds is well over 2,000. And so Secretary Deb Haaland has asked for an investigation for the United States boarding schools. And something that just hit home that I was talking to Wyatt about, and I'm going to rush through because I want to be able to get into the work we're doing right now, but we have to understand the importance of these historical things that happen and why we are here today. But one of our founding board members and somebody that I consider a mentor said that growing up, white schools had playgrounds, but boarding schools had cemeteries. And so I look at this photo and I, again, could totally get emotional as a mom of an 8, a 9, and a 10-year-old, but I have a son that has ADHD. He's on the spectrum. And you look at this photo, right? I wish I could make the photo bigger, but I could not get my son to stand like that for 10 seconds, let alone this room of children to take this photo. And there are hundreds of photos like this of American Indian children. And so we talk about what is historical trauma, and people are like, that happened in the past, but it didn't. So Wyatt, if you go to the next photo, to me, if I had to give a visual of what is historical trauma, we can totally look at this picture and look at the children that came to the school on the left. And it is the same 3 children on the right. So it's that, again, that forced removal of culture, of identity, of language, of culture, of that family unit, right? Like Wyatt and I showed our pictures of our families and how important that is to us. And so we look at these children as young as 3 again, who were removed. And the last one again closed in 1996 in the United States. And my dad's youngest sibling is, my auntie is, I want to say like 54. And so when her mom passed, her dad did not know how to be a single parent, not that he was, but he had his own issues. And we look at that trauma of, where his family was and his upbringing. And he sent my auntie to boarding school twice and she ran away. And he just was like, well, I guess you're not going to stay. So again, she's only 52, so it's not that much older than me. Next slide. So, right, so again, giving that context of why we share some of these important aspects, and it's not inclusive, it's not everything. The United States, again, has 574 tribes, and I look at, could keep us here till dinner just to talk about the Midwest or to just talk about Michigan. But we think about that trauma that's both historical and current, those stressors, right? What is that historical genocide and colonization, and how does that play out in who we are today as healthy Native people or lack thereof? And, you know, programs to really improve screenings or preventative health care. And so again, really just emphasizing so much of the historical context is that play out in the work we do today and why we are here. Next slide. And so what are those root causes of chronic disease? I will not go through all of these because I definitely want to hand it back to Wyatt. Right, what are those adverse social determinants of health? Those ACEs, right? Those ACE are those adverse childhood experiences. What are those behavioral risk factors, right? We talk about removing and reducing those burdens or those behaviors, but that is not something that will happen in a year within a community. It won't happen within a 5-year grant. That is something that has to happen over the long term with so many people involved. And then those poor health outcomes, right? Not just getting a cancer diagnosis, but the mental health, the physical health, that spiritual and emotional health, which all again lead to an early death. And I say that because I could totally walk down my mom's history here, and she passed at 56. And on that note, we're going to flip it to Wyatt because he's going to talk about the upstream approach and how we can work on all of these to better improve the work we do in tribal communities.
Yeah, thank you so much. That you know, I think is always the harder part to present on. So props to Melissa for getting through all of that. And I think, you know, I was looking on social media the other day, and I came across a graphic that talked about, you know, the importance of learning also about all of the success and brilliance and resilience of our Indigenous communities, and not just all of the stressors and the trauma and the suffering that happens. We have to recognize that, we have to know and understand that, but we also know that there is so much amazing work and that's going on in our communities too, and how we can lift that up. And so I think, you know, how we can work towards that is by engaging in this upstream approach to achieving health equity. And that means that we need to be support those positive social determinants of health, including the social and economic opportunities, increased access to healthy foods and sacred medicines. You know, Melissa talked a lot about some of the different policies that were enacted by the federal government, you know, that took away a lot of the access to our cultural practices. And, you know, where some of that has led to increased commercial tobacco use, we weren't able to, you know, access and use our traditional tobacco that plays a very significant role in many of our communities. And so people started using more of that commercial tobacco. And so how do we move away from that and educate and raise awareness on our traditional tobacco and how to use that properly? Also, having safe physical activity spaces, access to healthcare, education, housing, modes of transportation, access to the internet. We've all found out how important and critical that has been in the last year, and plays a significant role in health and health outcomes as well. So another piece is achieving full health is the potential, or full health potential is breaking that cycle of trauma. You know, we have to get out of that, and really includes the protective factors, including the cultural connectedness, a sense of belonging, resiliency, and practicing healthy coping skills. And by nurturing stable relationships, providing culturally tailored family education, connecting families to community system resources, and providing spaces for breastfeeding allows us to prevent, you know, those ACEs. And finally, by incorporating a balanced lifestyle, including physical, mental, emotional, and spiritual balance, we're able to achieve health equity and achieve our full health potential as Indigenous peoples and communities. Um, so, health equity is crucial for the well-being and vibrancy of our communities. And, again, that context, that historical context, we know that health is a product of the social determinants and health disparities. We have to have that historical context and knowledge if we're going to look at moving this work forward. All of the cancer control initiatives, policies, practices, evidence-based interventions, all of those things aren't going to be as successful if you don't implement and recognize the history and the other factors that are at play within the communities that we work in. And so we have to recognize and understand those. Again, those solutions have to be tribally led, community-based, and rooted in culture. So then, I touched on at the beginning of the importance of partnerships and developing those long-term relationships. Working with those tribes and communities means that authentic, meaningful collaboration. And so that means trusting that that community has the wisdom and knowledge to address the solutions specific to their community. Actualizing that positive change strategies by engaging with them and talking with them and saying what's happened, because something that's going on in the community today can very likely change and be very different in the next month or so, and that looks differently for all of those at least 574 sovereign nations, but we know that there's more than that. And again, I think it's so important to have those conversations so you can meet the community where they're at. They're going to have a different place in terms of capacity, resources, and all of the things that go into addressing the burden of cancer. And then, of course, cultivating that community-driven coalition to influence the policy and practice that's happening within that community. Also tribal sovereignty is a huge piece of this. So we, want to acknowledge that we as Native people are a sovereign people, and we can use that as an asset when leveraging positive change and health equity in our tribal communities. Tribal sovereignty gives our tribal communities the unique ability to govern our own policies and systems. And this is a key part of the work that we do. One example being within the research team, we have data ownership agreements that we have with our tribal partners, that the data and information that we collect belongs to them, and we don't get to use it without their knowledge and approval, and providing exactly how we're going to do that. As sovereign nations, that's a key component to or a way to honor and respect that tribal sovereignty. So as Indigenous people, we tend to walk too fast. We definitely have that experience of working within that Western model that the U.S. was built on, and the traditional practices and lifestyles that we were raised as Indigenous people. And so we need a framework for creating change at the community level, and we can do this by relating the Westernized concepts to our Indigenous worldviews. We can think of prevention, in terms of eating healthy and exercising, but as Indigenous people, we can also view it as having respect for our elders, taking the time to listen and understand the needs and priorities of communities, showing appreciation and respect for all the living things that are around us and how they are interconnected. So at ACAF, we understand the need to assess our way of life as Indigenous people when starting any new initiative. Our worldviews as Indigenous people has always been nonlinear when compared to the Western worldview. The Indigenous worldview is about interrelatedness, balance, and sustainability. Lifeways are rooted in culture and grounded in respect for all living things. Indigenous people are often our perspective is the collective in nature versus the individualistic. Collective culture emphasizes the need or emphasizes family and work group goals above individual needs, whereas individualism emphasizes personal achievement. Strengthening this interconnectedness creates opportunities for us to be healthier as Indigenous people. And this is the worldview that we use and use to guide our work.
Awesome. Thank you, Wyatt. So again, to kind of get more into the work that we do on the daily and really think about, that cancer prevention and control. And I wish we could just say COVID had no impact on that, right? So we're really at that critical point with some of our funding and some of the work we do and where we're re-engaging our urban and rural and tribal communities on the importance and why, what cancer screenings do and that they do save lives. So again, when we look at our programming and really thinking about that cancer prevention and control as a young organization and where we are is really, over the last 10 years, highlighting what are those preventable cancer screenings. And so a lot of the focus over the past 10 years has been on those cancer screenings. And so how do we increase that in Indian country? How do we balance that with all the other disparities of diabetes, heart failure, suicide, our missing and murdered Indigenous women and children and men. And so, trying to find where we fit on the plate. And sometimes it can get a little frustrating because it's like, just get your cancer screening or just fit it in that EHR conversation. But I love the work that we do and the resources that align with all of this and the tools and how we really want to, work with the clinic to improve those efforts and meet, like Wyatt said, meet the clinic and the community where they're at. If that doesn't happen, like the project is not even gonna go in the direction we want and be successful. ACAF, I think, really shines, and I love our social media. Our communications team is amazing. So the balancing that with the content, what is out there, what numbers and what data is out there, and how are we, raising awareness. So we have various cancer awareness campaigns that really promote screenings. Right now we are in our Powwow for Hope season, but already starting our Indigenous Pink campaign, which focuses on breast cancer, coming up with new and innovative ways to re-engage our relatives on the importance of that screening and that it is something that you should and could be advocating for your health. And so we do that with some of those culturally tailored resources. As Wyatt and I were developing this last weekend, I'll say, we think about, growing up there, I didn't see myself in posters, right? Even when I grew up using IHS as a clinic, you weren't represented in the posters or in your school things or anything health related. So really, seeing yourself in a visual and an educational resource, I think makes a difference to me. It drives home conversations I've had at home with my 9 and 10-year-old, with talking with friends and family. And so how do we really drive home those culturally tailored resources, trainings, and media tools? And Wyatt and I will share some of those here later. Community education, again, how are we giving those tools and resources to the community members who are the drivers, who are the grandmas, the aunties, the youth that are helping to make change in their community? And so a lot of the work we do focuses around that as well, a lot with our policy and prevention team. And then again, collaborating with clinics to help build capacity and improve their health system. Right now, some of the things we're doing is to really help with our survivorship efforts. Is there something within their electronic health record that can help identify, if they're a survivor, and what is the follow-up, and where are our cancer patients and on that cancer journey and that continuum? Like, how can we help make small changes again within that cancer prevention and control? And again, how do we, a lot of the funding we do has to come back to data, like what are the changes we're seeing? What are the screening numbers? And it's all exciting. As much as, part of what I talked about was heavy, I love the work we do here. It makes a difference. I see the need for our communities to have this work. I just want to double check with Chris where we are with time.
Again, we have roughly a half hour left. I'll give it all to you.
Well, let me slow down then. Thank you. Next slide. So as hopefully many of you are aware that most states have a 5 to 10, maybe 3-year cancer plan that has objectives and goals for their state to meet in terms of cancer prevention and control. So excited that ACAF launched its first national cancer plan, that really there are 41 urban clinics that receive funding under IHS. So they're urban Indian health programs. There's 41 across the nation. I talked a little bit about, how a lot of our urban areas have a high population of American Indians within their urban areas. So our goal within this funding was to deliver a cancer plan. So we have that really looks at those benchmarks that aligns with our funding. And then how do we build a coalition to help deliver this cancer plan, to help see that this cancer plan is usable and that it is that it's a helpful roadmap and that it's not just sitting on a shelf or, in a drive, but it's something that we can refer to all the time in terms of seeing what the data is and how can we even drive home the importance of those issues, those challenges, and those barriers in addressing cancer. And again, we're coming up on 2022, so reviewing the cancer plan where it's at and looking at proposing new potential strategies and how we can further this work. And again, the importance of stakeholders, right? They are just as much of a driver of this work as we are in the urban clinics that we work with. Super proud of this document and the staff that were involved in this and the communities that we worked with to drive home this, the development of this plan. Next slide. So kind of transitioning from, the work we do in the clinics and the communities, and again, emphasizing the importance of those culturally tailored tools and resources and educational materials. Our cancer plan is downloadable on our drive, and all of the resources that we're about to share with you again are also available on our website. So this one was created from our policy and prevention team, Indigenous Lifeways, our prevention. So it kind of went through that, Wyatt went through the Indigenous well-being. So same concepts here, just kind of goes a little deeper within the turtle. And then really, taking it back to how does this tie to who we are as Native people and what our ancestors did. And so again, when I talk about the importance of tailoring it to our communities, this one, again, our ancestors recognize that our lives are Wakan, which is sacred in Lakota. And so we have blank versions where if we have a tribe that wants to reach out and put in their tribal word for that, it doesn't take much for us to be able to swap out those words. And so just really, emphasizing the importance of communication and design in a lot of the work we do. And I think I have the next one as well. So as I mentioned, Indigenous Pink, our breast cancer awareness campaign is probably one of our larger campaigns. This one we did, I want to say 2 years ago. Check your Dudu Shiman, which in Ojibwe means breast. Again, and we do our best to reach out to various language experts who have knowledge and can help share some of these words with us. And again, we created a blank version that tribes can download and create our clinics. And so again, it's just knowing the signs and symptoms of breast cancer and understanding that you should see your doctor right away if you notice any change or abnormality. With that, I think, Wyatt, nope, I'm the next one too. Lung cancer. We have gotten, I think this year will be our 3rd year planning our Sacred Breath, which is lung cancer awareness, which happens in November. So understanding the importance of that connection to breath, right? And again, it ties into the work we do with both traditional and commercial tobacco, and understanding that lungs or Nia in Dakota are sacred. And so knowing those signs and symptoms of lung cancer. And again, tying those signs and symptoms to the work that we do through, CDC, ACS, IHS, various sources, so that we are giving the right information. And then again, why you should get screened. And this one probably has to be updated now that I think about the age, but yeah. So I think there's information on the back of this one as well, if you download the resource. And then I for real will pass it back to Wyatt.
Yeah, so, that information, is where we continue to work with the community to identify some of the different topics that are coming up and how we need to update and adjust things, because it seems like it's always evolving, and we want to make sure that we have the very best information for the communities that we serve. And so this is one of the examples which we model, or so the design of this is modeled after that last resource, because they go hand in hand. And we wanted people to be able to relate the two. And so this is our new latest updated lung cancer screening brochure that talks about what lung cancer screening is, how to get screened, and really helping to make that decision on whether or not you may or may not be eligible, but also walking through, community members what to expect and, how to get the best information, because this is all based on some a research project that we did and got feedback on a previous version that we had to understand what some of those barriers are. And so this is informed by that research project. And I'm not sure if this has already been uploaded to our website, but will be soon because it's just that new. So look forward to sharing that more. And then next, we have our COVID work that we've been doing. So, Melissa mentioned the impacts that COVID has been having on our communities. And so we have a project that's funded through the the Minnesota Department of Health to do community engagement and assess, kind of what are the questions, needs, priorities, and being able to respond to that information. And so out of that project, we've been, listening to the community and trying to help address some of those things. And so here, what's shown are some examples of resources that we've developed to respond to some of those things. Making sure that we're promoting that there are still ways that you can get your screening and protect yourself and your community. We have this, it's harder to see, but this on the right-hand side is a bigger poster that kind of, again, has a decision-making chart, some of the guidelines for the different types of cancer screenings, what to expect and how to prepare yourself for going in to get those screenings done. And continuing to promote, talking with your provider to understand, your risk and going in and getting those screenings done. So the other piece on this that we wanted to mention is the CDC recently released some information about the number of cancer screenings that were received by women through their National Breast and Cervical Cancer Early Detection Program, and that there was a decline by about 87% for breast cancer and 84% for cervical cancer during April of 2020 as compared with the previous 5-year averages for that month. And for American Indian Alaska Native women, that was a 98% decline in breast cancer screening. And so looking at how COVID has impacted those cancer screening rates and knowing that it's, probably not just for breast cancer, but all screenings. And again, the impact that that's going to have on our communities down the road of the missed cancer diagnoses that because of COVID. So, we're continuing to try to encourage that uptake of screening, as well as, continuing to address the barriers that people are faced with even without COVID.
And I think Wyatt and I both see the questions, so I think we'll have time at the end. Hopefully, I don't know if we can answer them correctly, but we'll try our best. And hopefully there might be others too on the call that can answer some of those questions. This is one of our newer resources, again, just really highlighting not just the month, but how we do this work throughout the year, but celebrating Indigenous life for our cancer survivors and where they are on their journey. And so again, honing into, what were those healthy ways of living, for our ancestors, for our relatives, and things that they did that we can really, bring back and try to live that way of life as we balance, also understanding there's times we may need treatment and, need to reach out to our healthcare provider, but just, again, how do we celebrate Indigenous life at ACAF with the work we do, with the clinics we work with in the communities. This past June, which I blinked and the month was gone. We did our first prayer walk, in honoring those relatives that we've lost to cancer, or those that are on their journey right now. Definitely love our cancer equity staff and the work that they do and how committed they are to some of our awareness months and really seeing how this work impacts our communities and our clinics. But again, you know, our ancestors' traditions kept us healthy. So using those traditional medicines, consuming natural unprocessed foods, maintaining daily physical activity and rest, connecting with nature, engaging in the community with traditional activities, maintaining regular medical care, scheduling screening, staying up to date on vaccinations, practicing safe behavior. So we ended up printing these banners and sending them to some of the clinics that we work with. And so just again, emphasizing the importance that, you know, even though they may be done with their cancer, their treatment, you know, they're still on that journey and they'll always be on that journey. And how can we support and uplift them? And I have kids in the background, as I've mentioned. And then our next slide, I think we have 2 slides and then we can probably get to questions. So excited to be leading and just stepping into this role as CEO, and where we want to really highlight and honor. And, you know, last year we were in virtual, so we did a virtual fundraiser, but this year we are excited to host our 10th annual Powwow for Hope, Dancing for Life, Love and Hope in person, again, taking into consideration that could change at any point with our community and the safety, and taking COVID into perspective. This event is happening Saturday, August 28th, here in Minneapolis at our Minneapolis American Indian Center. And so really, you know, when we fundraise as part of ACAF, as being a national organization, you know, being able to give the community an opportunity to heal and have this event, but also seeing, you know, some of the fundraising that we do operationally, and to do some, you know, to build programming that isn't always tied to a grant, or how can we expand on some of the survivorship care packages that we get out the door, or, you know, what are those things such as COVID, like how can we get gift cards out to our relatives so they don't have to go out in person, or they don't have to think about the financial burden that's probably already there from their cancer treatment and all the medical bills that add up. So when we think about why we fundraise and why we hold Powwow for Hope, and just being in this space of, you know, knowing we're at our 10-year and what does that mean and how do we really honor our community. So if you want to go to the next slide, Wyatt. And so as we're deep in Powwow for Hope planning and looking forward to coming together with our relatives, you know, we fundraise to be able to strengthen our survivorship efforts, to offer support to loved ones facing cancer. And so again, just an example, during COVID-19, we received funding and we're able to provide gift cards with those who have a cancer diagnosis to them and their caregiver. Again, building those larger cancer awareness campaigns to address the inequities, because we know some of our funding is not tied to swag. So how can we get some of those, you know, fun things out there to increase education and to increase awareness about the importance of screening? And then again, just our fundraising is, you know, those overall proceeds benefit the mission to eliminate those cancer burdens on Native people through improved access to prevention, early detection, treatment, and survivor support. So a lot of the work that Wyatt talked about in terms of, you know, how do we update some of that data, not necessarily tied to one of our grants. So it's, you know, trying to lean in on our evaluation specialists to help, you know, guide some of this work that's not restricted. So yeah, feel free to reach out to Wyatt us if you have any questions on Powwow for Hope or any of our resources. Anything? So again, from Wyatt and I will also let him, you know, give any last words. I'm so thankful to be in this space with all of you. Kitabi, Pilamia, thank you in my Meskwaki and Lakota language. We also have it written here in Dakota. Thankful to, you know, have these conversations, and some days they're hard, but I know that walking away, I'm happy to share these resources, and that I'm happy to share those impacts that happen on my family. And I hope that, you know, the change and the healing that we all have to do impacts our future generations. And that is why we are here, to have healthier future generations for our grandchildren. With that, I will hand it over to Wyatt, and then I think we might have time for some answers.
Yeah, I want to just echo, what Melissa had to say, and say thank you, to everyone for attending. Again, giving us the opportunity to talk through, the background of the work that we do, why we do it, and just kind of how we carry this work and moving it forward to hopefully improve on the health of our communities. So Pidamaye to all of you and to Karmanos for the opportunity and reaching out to, request some of this information in that context. This is that first step in addressing those health disparities and inequities. There's so much work to continue to be done, but sometimes this is that first step is sometimes one of the most challenging things to do. So thank you to you all for doing that and reaching out to us. And I think there's a couple questions I think that have come up in the chat that I can address. And then we can open it up for any live questions as well. So let me pull the...
And then there was a Q&A too. Did you see that one, Wyatt?
Mm-hmm. Oh, that one was in reference to the Cancer Burdens booklet. So that data and information is specific to American Indian and Alaska Native communities. On that booklet, there is a reference to the article that's, it's based on that data and information from there. And then let's see here. So I know there was a question about saying more on how access to equitable healthcare impacts missing and murdered Indigenous women. Melissa, if you want to chime in on this, I can start by saying that I know that for this one, but also the other question about resources geared towards LGBTQ S plus populations is something that we are hearing about from some different community members, and we recognize that those are topics and the need for information on those things. And so I'll say we're working on it, that we're hoping to, look for funding to provide or gather the capacity to respond to those things, because, it is a very real, unique aspects to those populations of providing that information, especially in terms of like getting good access to care, and especially your cancer screenings. We know that there's a lot of pieces to those experiences that are influenced by the experience that you have if you have different traumatic experiences. But yeah, all of that. Melissa, do you have anything you want to add there?
No, I think you answered that well. If anyone has a follow-up, let us know. I'm looking at could you say more on how to access equitable healthcare impacts of missing and murdered Indigenous women? I think what comes to me is the National Indian Women's Resource Center. Minnesota has a Minneapolis Indian Women's Resource Center that does programming. I feel like the majority, when we think about MMIW, there's so much work in terms of the actual missing and murdered individuals, and raising that awareness that there's not much done once they go missing, and it's usually on behalf of the family or the community that is fighting to find and return these individuals to their communities. I know from ACAF's perspective, when we think about those victims, right, and that healing, that is deep. That is something I don't know that ACAF can have a space in, but we have thought about the importance of that, advocating for that healthcare, which does include, HPV, cervical cancer, and, some of those other communicable diseases. Like, how do we go about that in a safe, welcoming way to the individual, to the victim? And, so we've, reached out to the National Indian Women's Resource Center to possibly start those conversations. I know, Beth Seeloff, who's on the call with Intertribal Council of Michigan, we've had some of those conversations as we looking at, women's health. But if you have a follow-up question, I would love to hear it. I think, and too, I don't know if you have anything, but I think too, a lot of focus is on finding those individuals. And I don't know that I hear enough about what that healthcare looks like if they're not near an IHS or near an urban clinic. And have to go to, say, a main healthcare system.
I also saw I missed the second part of someone's question about resources that specifically talk about tobacco and health and language in terms to use to talk about tobacco sold by industry versus traditional tobacco. So I think that this can definitely be very tricky in terms of how you talk about tobacco use. And so I think this is one of the instances where it's critical to talk with that community and try to understand, how they talk about, tobacco in their practices and protocols and how they refer to it. So I know, for Dakota people, we have, our terminology for that and talking about that in that way, versus, and so I think like part of how we talk about commercial tobacco is calling it commercial tobacco and recognizing also that, sometimes people are still using that in ways that they maybe shouldn't, or, I guess, I would just say like we probably go with commercial tobacco over just the standard like tobacco in everything, because if you say just tobacco, then that's kind of including both of those perspectives.
You got another question, Wyatt?
Example about how, where did that go? About why or how to present data about communities. So presenting data, again, this is where you have to engage at that community level to understand the context of what that data and information means to that community. Even myself as an Indigenous person, I don't know and understand everything that goes on and happens in every community. So it's important to say, here's what the data looks like, and having a conversation with that community and the leaders there to say, this is what's there. I think it's important for you as in a community to interpret that versus me as an outsider, because I might not have the full context of what's happening there. And so that's why it's like I can interpret it and get something out of it, but an outside person can have a completely different interpretation of how that's going to be received. And so when I contribute to a research study and provide data, I want to know that it's going to be respected and talked about in the best way. And so I think that sometimes that's a hesitancy of Native or Indigenous communities participating in research, because like what's going to be done with it, and if there's the perception that it's not going to be handled right, who knows how accurate or valid the data would be.
And I was trying so hard, Wyatt, not to talk about KIRCA, the Collaborative Research Center for American Indian Health, which is a National Institutes of Minority Health and Disparities grant that Wyatt and I both worked on in, lifetimes ago. But really tribes are starting to have their own tribal IRBs, and being able to have a say on what research is conducted in their community and asking that questions like why, they're asking the researcher, why do you want to do this? How does this benefit you? How does this benefit the community? And that IRB is going to be with you the whole way, even through manuscripts and when your research is done. And, understanding is that who's going to look at that data next to do a secondary data analysis. So, I could go on a tangent because I think about the importance of tribes, learning and being able to have a say of what research is done in their community and how that data will be handled for the long run, and that the tribe will be the sole owners of that data. But you had another question, Wyatt, so I'm going to pass it back to you.
In terms of the health impact differences between traditional and commercial tobacco, I don't know that there is information or data out there, at least not that I've seen, that's come across about comparing those two. But again, I think that every community has their own unique relationship with tobacco in terms of why they use it, how they use it, what they use, all of those things. And I don't know if there's anyone that's actually looking into those differences. But I think, again, more importantly, it's about respecting that relationship that we have as Indigenous people with that traditional tobacco that plays a very significant role in many of our communities. And so it can be really challenging to approach that topic. And so because a lot of times, there could be information in there that's just, really valuable. So it can be challenging to navigate that conversation. But again, would encourage those local, more, just the local discussions about what that means for individual communities.
I oftentimes think there's a misconception, right? When we think about commercial tobacco, we know you're inhaling it, right? Where oftentimes traditional tobacco is not used in that sense. There's, it's not even that it's burned every time. Sometimes you take the traditional tobacco plant in its form in your hand and you offer it and you pray. So it's not that it's always burned, and it's, I would say, rarely inhaled. But again, Wyatt makes a really good point that, we are individuals belonging to certain tribes, and that, even some of the tribes in Michigan may have different ways they handle and respect their plants in their community.
With that, I just want to I'm very thankful on behalf of the Office of Cancer Health Equity and Community Engagement, and to speak on behalf of KCI and McLaren Healthcare. We're just so thankful for Melissa Buffalo and Wyatt Pickner to share their expertise and their emotion with us today. And again, for individuals, this recording will be made public. We're going to be putting it on YouTube. I've had a number of individuals, maybe some of your coworkers have asked about it. It'll be made public. We'll be putting it out. And again, we'll also be sharing in that email out for folks who have registered. We will share the YouTube link, and then we will also share additional materials from AICF. There was a number of very many positive comments about the very wonderful illustrations. Those resources are available on the website. And so we will share the cancer booklet, the resources, also their YouTube page, their Facebook, and then there's some of the resources that Melissa mentioned, the Dakota 38+2. That link, there's a number of videos on YouTube for that. And again, as on behalf of Kimberly Keaton Williams with McLaren, Noel Larkin, Dr. Haley Thompson in the Office of Cancer Health Equity and Community Engagement, on behalf of my coworkers, again, thank you very much, and we will talk again. Have a wonderful night.
Thank you.